I'm Dr. Barry Ramo. Welcome to the New Mexico Heart Institute on the Go. Today, Dr. Fenton McCarthy, cardiothoracic surgeon at the New Mexico Heart Institute, will talk about advances in aortic surgery at the Loveless Aortic Surgery Center. These programs are sponsored by the New Mexico Heart Institute Foundation. The program has been certified for 1 hour of continuing medical education.
My name is Fenton McCarthy. I am one of the CT surgeons here at Loveless, and I'm going to give a talk today on advances in aortic surgery and introduce a new initiative that we're doing here at Loveless with a dedicated center towards aortic surgery. Just as a kind of 5,000-foot view when we talk about aortic surgery, the specific aortic pathologies and therapies that we're talking about most commonly have to do with, in the CT surgery world, ascending and aortic arch aneurysms. There's different phenotypes of those, different indications and different operations. We have dissections that, for the vast majority of cardiac surgery, have been broken up into type A and type B. That's changing quickly, and I'll get into that a little bit more. But in general, a type A dissection is a dissection that happens close to the heart, and a type B dissection is one that happens a little further down the arch. We do different surgeries, different therapies, different management for both those pathologies. I'm going to use the dissection story or the dissection example here to tell a story about aortic surgery, to sort of narrow our focus and to try to fit it all within the time, because as most folks know, I would probably go all day with this if I had the opportunity. By and large, dissections have been grouped into Stanford classifications as type A or type B. And what this figure is indicating here, I'll try to illustrate it with my mouse, is that a dissection is when the layers of the blood vessel peel apart from each other. So the inner smooth layer, or the intima, develops a tear. Blood then can get behind the intima and into the media and develops this new place for blood to go. It's called the false lumen, that's in between the adventitia and the intima. That change in the aorta makes it structurally never the same and never as stable as it was before. And I think, as this figure maybe isn't intended to indicate, but it does, this false lumen does not have the same structural integrity as a normal blood vessel. And so it always enlarges. And I'll show some CAT scans that demonstrate that really clearly later on. DeBakey, famous surgeon, famous heart surgeon, had his own classification. So we went from the sophistication of a type A or a type B into a sophistication of a type 1, type 2, or type 3. That classification never really caught on quite as much as the Stanford classification for type A and type B, by and large because Stanford type A dissections were operative emergencies and handled like such, and type B dissections historically were always handled with blood pressure control and medical management. The world is changing quickly, though. So this is how we think about dissections now, and this will probably continue to advance. So this was a collaboration between the two major surgical societies that deal with aortic pathology, the Vascular Surgery Society and the Society for Thoracic Surgeons. And what we're looking at here is, instead of the aorta being divided into an A and then an area that wasn't ever really particularly defined, and then a B, which was after the subclavian artery, it's now broken down into 12 zones. And what we are evaluating now is the extent of the dissection, where the dissections, where the tear starts. Sometimes the dissection can propagate proximally, sometimes it can do distally, sometimes it can do both. And so, we're proper dissection classification now, according to the major professional societies, would be something along the lines of a type B4, not necessarily just a type B or a type 3 that we used before. I like in my talks to sort of do a moment where we look at what I think is the oldest, most significant data, and then also what is sort of the newest and most surprising data. And I think it's always worth revisiting this slide. And essentially what this is looking at is people who had type A dissections, and whether they were operated on or not. Oh, sorry, I should correct that. This is looking at type A and type B dissections. And what it's showing here is that the type B dissections, when managed medically, had this survival curve, and the type A dissections, when managed medically, had this survival curve. There is nothing in medicine that has a survival curve that looks like this. Essentially, it's untraceable. It's a mortality that's measured in hours and even in minutes. And it's why whenever we find that pathology, that patient is rushed to the operating room as fast as humanly possible, usually bypassing all other avenues like the ICU or the ED, and we try to get that fixed as soon as we can. I think kind of the newest and most surprising dissection data that I've seen was a study that came out of Japan, and actually it looked at out of hospital arrests. So these are people who died without ever making it to the hospital. And when they did autopsies of these patients, they found that 7% of these patients died of type A dissections. This paper has changed almost every conversation that I have with a patient when we're talking about their risk for dissection, because by and large, there's a lot of people who say, you know, my uncle or my aunt or my mom or my dad just died suddenly of a heart attack at home. And chances are that might be correct. You know, we're still only talking about 7% of these people. But by and large, if you see somebody who has a risk for dissections, aneurysms, and ruptures, I think it's really likely that that was actually an aortic event and not necessarily a heart attack. This is a video from the operating room showing a type A dissection. And I love putting this in these talks because I think it shows just how dangerous this disease is. So to kind of orient folks a little bit, you know, this is the heart moving there at the top of the screen. The head would be at the bottom of the screen. You're looking at the aorta right here. And what you can see in there are two things. One, you can see the flap. That's the intima of the aorta that's going back and forth in there, moving with every heartbeat in the heart. And then I even convinced myself that I can see the individual blood cells moving here. And what I think this is really showing us is that the thinnest of layers is really what's keeping that aorta intact. And why these people die is that aorta ruptures. And so you can imagine that it doesn't take a whole lot more for that aorta to rupture. So how do we fix these? And why does it matter how do we fix these? And I think this relates a lot to a lot of the efforts that we're doing here. So what you're seeing here on the right is a CAT scan of somebody who had a quote unquote repaired dissection. And what you see there is that the dissection, if you're kind of familiar at looking at these scans, and it'll loop through here, as we go from the head down into the arch and into the ascending aorta, there is still a lot of aorta there that is dissected. And as we mentioned before, the aorta that's dissected is never structurally the same. And so a lot of why that happens is because when these dissections get fixed, we have to put a clamp on the aorta and fix whatever is this side of that clamp. But what happens when you do that sometimes, if somebody has a bad dissection, is that it leaves dissection in the ascending aorta. And that really goes on to cause a lot of problems down the road. What we advocate for is to get people, when they have this problem, to fix it as into the greatest extent possible. And that means really taking out a lot of that ascending aorta. So, you know, what isn't visualized here is the heart down below, but this is the entire ascending aorta up into the aortic arch. So whereas before that dissection was still present in this part of the aorta and put all the arch and the head vessels in jeopardy, this technique of fixing dissections by opening up the aorta and getting all that disease pathology out is what makes a big difference for these patients. For folks who don't know, you know, I've been in New Mexico now about 3 years and have been talking a lot about aortic surgery and aortic dissection surgery for a lot of that time. You know, and as a result, I have a significant number of patients who are now doing redo aortic surgery for this very reason, because that part of the aorta was left behind. So when we think about a dissection surgery, these are all the things that we're thinking about. And I'm not going to go into all the details here, but when you have a dissection, it can disrupt the function of the aortic valve. So we have surgery to address that. It can affect the blood flow to the heart. We often need to do surgeries that restore the blood flow to the heart, either a more robust aortic surgery or even bypass surgery. We need to figure out how we give blood flow to the brain. When we stop the heart and stop the pump in order to repair the aorta, we need to make sure that we maintain blood flow to the brain. And then we need to, of course, replace that ascending aorta to prevent it from rupturing. So fundamentally what this looks like is we're trying this is this dissection, and this is the part of the aorta that we all need to take out and needs to be repaired. It's the goal. In a way, it sort of looks like this, where we're looking proximally, meaning closest to the heart. And what you're seeing here is the heart around this and the valve behind it. This is how we repair that aortic valve. We need to fix it more distally, meaning closer to the aortic arch and as the aorta traverses the body. And that means reconstructing the aorta and replacing the ascending aorta with a graft, connecting those back up for our final problem. This is for all those familiar with aortic surgery, this is what we set out to do. And it's important to think about this in terms of what makes the difference in terms of the patient surviving. And this paper, I think, is something that needs to be more widely distributed. It was a circulation paper from 2019. And as we talked about before, the mortality for type A dissections, is measured in hours. And so we do want to get that patient fixed as soon as possible. But what we are realizing is it matters, one, how you fix it, which is what I was talking about before, and it matters where you fix it. So this paper looked at two things, and there's two slides I'll use to talk about it. The first was, the basic idea was, did it help patients to transfer them to a high volume aortic surgery center? And the two fundamental questions that have to be addressed there was, did the patient do better because they got the surgery there? And did the patient suffer any harm because they had to be transferred? Because it takes more time to move people. So this first graph shows no difference. And that's important because this is looking at whether transferring the patient, the time that it took to do that, did that affect how their outcome was? And it did not. So what you can see here actually is the red curve is people who were transferred. The blue curve was people who were not. And the mere fact of transferring them did not adversely affect their survival. That's when you look out 15 years. Before that, the red line here has a lower probability of death. So if you want to be on a line, you want to be on the red line. The second one was, did it matter if you got the surgery at a high volume center or a low volume center? Again, we're looking at probability of death. So you want to be on the lower curve. The red curve here is people who got surgery at a high volume center. And what they did is they had a 7% absolute survival advantage by getting surgery at a center. So we've got a small audience. This is, I promise, the only moment of audience participation. I'm just curious what people think defines a high volume center. Doug Brown, any ideas?
A center that performs lots of surgeries.
Surgery or emergency aortic? Any aortic surgery. 20 in a year, 40 or 50 in a year, 7 proximal surgery operations a year. And to be clear, what defines a high volume center is this is the top 10% of institutions in the country. So 90% of people who do heart surgery out there do less than 7 aortic operations a year. Emergent, elective. A few caveats. What we're talking about here is an aortic root, an ascending or aortic operation. And this study looked at just Medicare patients. So how does Loveless compare? So I took a look at our aortic surgery volume. Full disclosure, this isn't a true apples to apples comparison because I don't know whether these people are Medicare or what insurance that they have. But in looking at this, in 2019, we were doing 30 of these operations, and by 2021, we're almost up to 60. Some other things have happened in those years that we've noticed. by and large, I'm talking about COVID. COVID has really affected our ability to do heart surgery because we fight for the same resources in terms of ICU beds, ventilators, ICU nurses. And then one more further disclosure, this is just a single surgeon experience. So this was just me. And although I do a lot of aortic surgery, our group as a whole does a whole lot. And so I think this is a really important message that we're a busy aortic surgery center, and we're also a group that does a lot. So what we've done is created an aortic surgery center. This is really important because what we're trying to do is communicate out to the outside world, that this is a place that specializes in aortic surgery. And we're not just making a claim. What we're saying is that we do a lot of this, and we do it, we get excellent outcomes for our patients who have aortic surgery. So this was an initiative that just launched this month. It's live now. You can go and look it up, and it talks about all the surgeries that we do. But I think most importantly, it talks about our multidisciplinary approach to aortic surgery. And this is, I think, the only reason that it succeeds. It is a big team to do these complicated surgeries. Here at the Heart Hospital, we have 2 dedicated service lines to this in terms of cardiothoracic surgery and vascular surgery. I'm not even touching on all the aortic surgery that takes place before the diaphragm, which is an absolute incredible volume of aortic surgery. We have dedicated cardiac anesthesia, our whole OR team, which includes perfusion, who are specialized in doing these operations, which are often involve perfusing the heart and the brain and the body in different ways and at different times during a single operation. We have a dedicated OR team, and this is just kind of a abbreviated list. I'm sure there are other folks too here, that are part of this team. And it's come to the point, here at Lovelace, when we're doing a big aortic surgery, nobody's surprised. That's not a day that people feel like, is planned ahead months, weeks at a time. It's something that's commonplace here at our institution. It's not just about the OR, because we also have to have a dedicated ICU and hospital team, includes intensivists, nurse practitioners, PAs, nurses, our consultant physicians, and then our entire outpatient team who gets these people ready for surgeries on an elective basis and follows up with them afterwards. Our entire office staff and our imaging folks who do just such a fantastic job, allowing us to plan and track for these patients. Yeah.
Say that just hypothetically resources around.
So for folks who might not have heard Dr. Castlemaine, because I think I'm the only one who's mic'd, his point is that the institutional investment, in its human resources as well as its brick and mortar resources, and making sure that we have those folks have experience and are familiar with the team is a big part of getting good outcomes. And I think everyone absolutely agrees with that. So what do we do at the Lovelace Aortic Surgery Center, that make it a specialized center? We have minimally invasive therapies. For us, these most commonly come in the form of endovascular therapies, where we're using stents and other catheter-based techniques to treat therapies. For us, by and large, this is in the type B dissection world. And I do try to not have that nuance get lost in the bigger message, because in terms of some of the most important developments in our field, I have a case example of this later, but for folks who have the type B dissections who have been followed medically, it's worth bringing them back around because we do treat those surgeries differently now. We treat our type A dissection surgeries differently. I tried to go into a little bit of the details of that before in terms of, some ways to fix that get the patient through, but leave them with other problems, and then being prepared to do as much as you need to in order to plan both for that operation and the next one. And then the last thing that I'll touch on is aortic valve repair, which is a new and exciting field. And we're really unique in New Mexico and as an institution that can offer that. So the endovascular therapies that we're talking about here is really the Tavr, which is the thoracic endovascular repair. It's technology that's really built off of abdominal aortic aneurysm endovascular repair, or bars. And what's happening is we're just marching closer to the heart with these stents to fix either dissections or aneurysms, or like I say, oftentimes a dissected aorta will then grow and become aneurysmal. And we use stents to fix these more and more. And what's coming down the pike in future developments are stents that have branches that can then go off into these arch vessels, and stents that are used in the ascending aorta. And if I have some time, I'll get into that at the end. I don't know if I will though. And then we're combining these procedures more and more commonly. And so, common operation that we do here is called a hybrid arch. And what we're doing is, in part, we're fixing this aorta with open surgery because that's still the best and safest way to do that. And then we're using stent therapies to extend that. And it's become so common that one of my partners, I think, jokingly said, "I want to be a zone 2 arch for Halloween." So we're a team. We share our outcomes and share our patients. And so the cardiologist here, Dr. Coons, didn't know he was going to be part of the presentation. But it's one of the reasons why I love my job. And I love it. I'll just kind of ground it in an individual case here. This was a patient that we had. He was 58, so very young. He originally presented to an outside facility with a type B dissection, and he attempted medical therapy with blood pressure control. And this is what we saw, and this is kind of why I started the talk in terms of a type A or a type B dissection. And this is the same CAT scan, kind of just taking slices axially and coronally here. So these are sagittals. And so what you see, is that this dissection, it's in the arch. It's not down here in the ascending aorta. It's up here in the arch. And so, historically, this patient would have been just treated with medical therapy. But what you can see is that already within 6 months, this aorta is falling apart. And so, this is this false lumen that I talked about that doesn't have the same structural integrity. This is the true lumen, that tiny sliver of a thing on both of these images where the blood flow is supposed to be going. And so what are the options to fix this? One of the options is a thoracoabdominal aneurysm repair. This is an incision that goes in between the ribs, essentially from the scapula to the navel. I think I put this picture in, a little bit for dramatic effect, but this is, a hand. And so you get a feel for the size of this surgery, the size of this incision. It's one of those surgeries that are very, very hard to get people through. And then, as Dr. Castleman was alluding to before, just getting them out of the operating room is not determined success. And so people have to fully recover from this whole operation. I personally try to design our surgeries so that people don't have to have that surgery. And so by and large, this is what we're talking about before, where we'll reconstruct the aorta partially with open surgery through the front, still very invasive, but far better tolerated than surgery through the side. And then use newer techniques to extend that therapy with stents. So this patient came in and got their stage surgery. So the first stage was a carotid subclavian bypass, which is this connection here. We did followed by a zone 2 arch with Jeff Koons' Halloween costume, and then brought him back for an extension Tavr about 3 months later. So this is the end of the zone 2 piece here, and you can see the head branches coming off there, and then we can park a stent. We've got all this territory to park a stent in when we need to. So we brought him back for the Tavr extension and did a stent essentially from this reimplanted carotid artery down to his celiac artery, which is the first artery off the aorta in the abdomen. He went home without complications on day 4. And then if we look at what that looks like here, this is that fixed aorta. And so these are these head branches coming off here. You see kind of the bright circle, that's the stent. And over here on this side, sorry. And then this is here now with that true lumen opened up for the patient.
What influences your decision to put stent or apply the stent at the time of surgery versus coming back to it?
So the question was relates to how we use the stent therapy, and the more kind of tried and true traditional way to do that is we bring the stent up through the groin and deploy it, and then sometimes, you know, when the aorta is open and we're doing the open heart surgery part, we take the stent and go forward with it. And we use kind of a different approach tailored to the exact aortic pathology. But the best answer there is that if I think that by putting that stent in at the time of the open surgery, it helps stabilize that part of the aorta in a way that we can't do it later on so easily, I think that that's worth it. It is an extra step at a critical part of the operation, so there's always increased risk added with that. So to me, that's kind of how I try to think about it is, you know, if we can come back and it's going to be doable through the groin, that's probably safer. It divides the risk. If we can't, then putting that stent there makes that part easier. And also then you go back and put a stent inside that stent, which is something that technically is not too difficult to do. So I pulled these apart. You know, this is the pre, where we had that tiny piece of true lumen aorta there, that sliver there. And then this is the post. And then this is the post reconstruction here. And again, you see this false lumen now shrinking because it isn't pressurized anymore. And so that leads to aortic remodeling. I've seen him now a year or two out, and the scans continue to look better. So very happy about that. The last thing that is really important, you know, about our aortic surgery center here is aortic valve repair. This is also new and exciting therapies. And, you know, for folks who have followed heart surgery either closely or peripherally, you know, what we've seen is kind of two, I think, big trends. The first was in the approach to mitral valve therapies and recognizing that there's a lot of mitral valves that could be repaired, certainly not all of them, but some could, and the people who could did a whole lot better. To be honest, the world of aortic valve surgery is catching up with that, but it's probably 20 years behind. So right now, what we're seeing is when the valve repair techniques were being perfected and distributed for the mitral valve, so it was no longer an experiment. You know, it was something that certain centers had perfected and is now being more widely released. You know, that's where we are with aortic valve surgery. And so, you know, what I believe is that we should be doing is more and more aortic valve repair surgery every year. And that's what we've been doing. And so, you know, we're now doing what's called this valve sparing root replacement, which is usually used for young patients in certain circumstances who have a working aortic valve, but a diseased aorta around it. So that surgery allows them to keep their aortic valve, which by far offers them the best outcomes. And then some newer techniques, you know, that I think we'll be seeing in the coming years involve rings that take the shape of either a tricuspid or a bicuspid aortic valve. And I'll talk a little bit more about bicuspid aortic valves later. And this is almost directly borrowed from the mitral valve space in terms of using a preformed structural matrix in order to bring that valve together in a way that makes it work and offers the patient a long and effective therapy, a durable and effective therapy, I should say. So the David 5 technique, essentially what it looks like is you want to save the aortic valve tissue of the patient and the tiniest little bit of aorta around it, but then you're going to take all of that and sew it inside of a Dacron graft. There's some science to it, but there's also a little bit of art in that you're trying to get all of this geometry right and all of these ratios correct, because this is the only way that aortic valve, when you reconstruct it, works in a way that those leaflets come together and the valve doesn't leak. If you distort that valve, then that valve will not work the same. So it's not something that we should be trying here and there, similar to the high volume centers and the low volume centers. And then the idea here, sort of just schematically, is to remove the diseased aorta, replace it with a Dacron graft, and then again do that in a way where the valve sits inside of the graft. This is what it looks like in the OR. And believe it or not, we do keep track of all this sort of string spaghetti mess. But really the idea here is, this is a normal valve. And so you look at this and, this patient deserves to keep that valve. The other two important structures here, are these coronary arteries. We have to reimplant those, that preserves the blood flow to the heart and heart muscle. And then this is what it looks like when you put it back in. And so that's what we were talking about before. We're keeping these normal leaflets. This is better than a tissue valve that's come off the shelf. And we're now approaching 30 years of experience, with these valves, but it looks equivalent to a mechanical valve in those patients as well. So who might be a candidate for this operation? Like I say, anybody who has normal aortic valve tissues, but a diseased aorta around that part of the aorta is called aortic root. Certain type A dissection folks. Again, these are the people who can often be young and otherwise don't have a lot of cardiac comorbidities in terms of valve disease or coronary disease. So those people oftentimes have a preserved aortic valve as well. You can do certain cusp repairs. That means you repair the aortic valve tissue as well. But then there's a big category here, and this is sort of where we'll spend the rest of our time, is talking about people who have a bicuspid aortic valve. Now, normal human anatomy here is like this. I'll kind of flash back when we have these three cusps. A bicuspid aortic valve means that either two of these cusps are fused together, or you truthfully just have two leaflets. And so this has really been affecting all of our guidelines and all the professional recommendations in terms of how we approach aortic disease. So the American College of Cardiology and AHA in 2010 came out with this approach to thoracic aortic disease. And, in terms of a broader message, and if, folks who don't deal with aortic surgeries, every day, these are kind of some rough numbers that get people into the operating room. So that might be an ascending aorta greater than 5.5 centimeters, a descending aorta greater than 6, a rate of growth of 0.5, or anybody with symptoms. But the reality of it is that we deal sort of in a more medically gray, human complicated world where, not everybody comes in with just, sure, if they have one of these, it makes the decision easier. But far more commonly, you have folks who have aortas who are in the 4, 4.5, 5, 5.3 range. And how do we approach these people? If those folks are getting heart surgery for other things, such as valve or coronary disease, we have a low threshold to replace a diseased aorta, kind of the while you're there approach to it. And then there's an important group of people who have connective tissue disease where we need to be more aggressive in how we treat aorta, aortic pathology. So those classically are Marfan's patients, Loeys-Dietz patients, and then bicuspid aortic valve disease. The bicuspid aortic valve one is the one where I spend the most time on. because population-wise, it's by far and away the most significant. So it is the most common congenital heart defect in adults. A prevalence of somewhere between 2 and 5% of the population. And then if you look at folks who also have an aorta of 4.5 centimeters, what you're looking at, if you say, okay, well, in a normal aortic situation, we would wait to 5.5 centimeters. We're a little bit worried about these bicuspid aortic valve patients because we also believe their aorta isn't normal. But the societies really struggle with where you sort of mark that number, because the lower you move down, in truth, you'll prevent some people who would have an aortic event because you got surgery before that. But it also really increases the pool of people who are having this surgery. So just as how Deeds made this example, so if you use an example of 4.5 centimeters, that means we're talking about 1 million aortic surgeries. If you talk about 4.0 centimeters, you're talking about 3 million surgeries. And I think the point there is that feels like the pendulum has swung too far. So that's probably not, it's a balance between those two. The American Association of Thoracic Surgery has tried to help weigh in on this a little bit, and specifically how we answer the question of the bicuspid aortic valve disease patients. And I think if I were just to sort of summarize it with folks, they didn't really clarify all too much in terms of the exact dimensions, but their biggest emphasis here is that these patients should be treated at aortic referral centers. And it's, I think Loveless absolutely is that. And my mission is to just broadcast it in a way that folks know what it is that we're doing here. So to kind of wrap it up here, if you're seeing patients, who don't have any other concerning findings, we would take them to the OR if their aorta is 5.5 centimeters. And we would fix it if we were there if it was 4.5. The bicuspid aortic valve disease world continues to debate. And so I'm very transparent about this with all the patients who I see who have a bicuspid aortic valve, and they have an aortic dimension of 5.2 centimeters, and say, there are some folks who would say that this should be fixed. There are some folks who say we should wait a little bit. There's no exact right answer there if you're in that gray area. But I do think people should be able to be informed about their consent for that procedure. For other more serious aortic syndromes, or ones that are more likely to have an aortic event, such as a dissection or a rupture, we are more aggressive. So those are patients who have Marfan syndrome or Loeys-Dietz syndrome, which are all congenitally triggered aortopathies, where dissections and ruptures happen at smaller aortic dimensions. A few other things that we're considering, if the aorta is growing more than 0.5 centimeters, so if you have somebody who's 4.5 and then 6 months later they're 5, that's very concerning. A first degree relative with an aneurysm or dissection should lower your surgical threshold. And kind of back to that early study of people who have sudden cardiac death, to me, that is an aortic event, and somebody who we're looking at who has all these other aortic risk factors, and we should consider it as such. And then, a new area that we're dealing with in cardio-aortic surgery, which is true, I think, for cardiology as a whole, and actually, for our health system as a whole, is how we treat women's health. And so this is something that I think we've done a poor job of historically. And so we need to hold ourselves sort of more accountable to those considerations. And, what we realize is that, if you are a smaller female, that you should have an aorta that fits, your body phenotype. And, the example I use is that LeBron James should have a different size aorta than Simone Biles. And so, if you're a small lady and you have a big aorta, that's something to be really, really concerned about. So there's a push in the field to sort of look at an aortic size that's indexed by both gender and body surface area. Some things that are coming down the line, like I said, there's always new and exciting technologies for aortic surgery. So we're moving these stent therapies closer to the heart. So what's shown here is that this is blood that's sort of exiting the aorta in a contained way, but in a way that shouldn't be there. And more we're moving these stents up, like I say, sort of started in, I think, arteries in the legs, and then up to the abdomen, into the chest, and now we're kind of making the bends to the heart. That's kind of what this would look like on a CAT scan. It's a tough place to put a stent because that part of the aorta isn't fixed. It moves around constantly and with every heartbeat. And then, you know, this is sort of, you know, these are clinical trial images, so these are not done here in New Mexico. But I don't anticipate that it's long before we do start to see things like this. You know, where pathologies, you know, like this, which would be tough to fix through the front, through the side in any way, are getting reconstructed with stents in a way that not only fixes the problem, but in a way fixes the problem that's much less invasive for the patient. Yeah, well, hopefully that don't come for it. Getting back into that aorta would be hard. That would be true. And then, you know, these technologies will be synergistic. And so, you know, what we see here is a Tavr valve. And so that's, you know, a therapy that we do very commonly here where we replace the aortic valve with a catheter. And then this is the Tavr valve, or the Tavr stent. And you can imagine that, you know, these two technologies will meet in the middle here at some point. So that, you know, is my take on the kind of new aspects of aortic surgery, our aortic surgery center here at Loveless, and introducing that, and we'll be talking about it a whole lot more, but really want to thank everybody for joining kind of early this morning and appreciate their attention. Any questions from the audience? Mark Beniers.
So with this sort of fix of the external opening the bicuspid valve, how often do you think that the bicuspid valve is left above doing this thing?
So the question is, when we are doing surgery primarily for proximal aortic problems, usually an aneurysm, maybe a dissection, and we encounter a bicuspid valve, how commonly that valve could be preserved. True percentage, I don't know if I could say, but I really think that the mitral space is really leading the way for us. And so if you have a stenotic bicuspid aortic valve, that valve should go, similar to a mitral valve. You know, repairing narrowed valves conceptually, you know, you're not going to get a good outcome there. So, you know, in the bicuspid valve world, you know, as we've seen for a long time, there are patients who have perfectly working valves. There's patients whose valves leak and patients whose valves are narrow. You know, what I would say is that of the patients who have a normal bicuspid valve, those should all be saved. Patients who have a bicuspid valve that leaks, we should be holding ourselves accountable to a higher and higher bar of saving those valves as commonly as possible. So I think the question was, what's the natural history of bicuspid valves? And I'm going to dodge the question a little bit, but also try to answer it a little bit too, in the sense that from a surgical perspective, I think we want to know at least kind of where we are now is, you know, what is the durability of an operation that preserves a bicuspid valve? And those are people who we should identify and track and be able to know the answer to. And so what we see is in that field, you know, it's 90% durable at 20 years. You know, so similar to the mitral space.
Which valve is that? That's a repaired bicuspid.
Mm-hmm.
That's not stenotic.
That's not stenotic.
I think where Mark's coming from, and I have the same bias. You see people with bicuspid aortic valves. We follow them for years, and we say eventually it's a bad valve. It's eventually going to come due. And intuitively, we're thinking you're getting an operation. You're going to need that valve replaced at some point. There's a big population out there that we never see. Right, right.
In your answer, the answer to your question is no, because there's no long-term, because there's no population study that are good enough to say those 2.5% of bicuspid, they don't all be the same, right? Because some can go down the path of stenotic, some can go to leakage, and some can go to a combination of both. And this is not something that I don't think any of us has a question as an answer. So again, this is how it's going to take
And so, I mean, to me, I think it begs interesting questions of, like calcium processing in the body. So like, why do some people with a bicuspid valve calcify that thing and it becomes a stenotic rock that really needs to be replaced? And why do some people have tissues, that literally have no calcium on them whatsoever? So I think we have to expand our thinking a little bit. And then I think traditionally the sense was, it was an aortic stenosis driven conversation that says when you have, senile or whatever, tricuspid aortic valve stenosis, we expect that you'll have a problem at this point. We know that we see that in bicuspid valves, earlier in life. But then I think a lot of folks have made the natural logical jump to sort of say, okay, well, we would expect to see this in all of these bicuspid valves. And so you sort of might see a patient and say, yeah, I expect this valve will fail for you, and at some point, and you'll need a replacement. And I think we should be really honest with folks. And I don't think I would see somebody with a bicuspid valve and say, this is not going to be a thing that perhaps takes your life and you will die of something else with your own bicuspid aortic valve. I don't think we're there. But I think it is fair to say that, we're learning more and more about bicuspid valves. And, some people don't need an operation. Some people do. And some people who get that operation get their valve replaced. And some people, are able to keep their own valve. Questions from the